Hi, my name is Chango. I'm going to talk about a randomized trial of hyperimmune to prevent congenital cytomegalovirus. Definition: Cytomegalovirus is a common virus and primary CMV infection that develops in a woman during pregnancy, confers the highest risk of congenital infection and disease. Similarly, 20% of these infected newborns are symptomatic at fever or with health difficulty, such as sensory neural, hearing loss, cognitive defects, and motor defects.
I was angry. I was angry that I had never heard of it.
I studied child development, I studied psychology, and I had never heard of it. And I was kind of frustrated, first of all, that my son was affected by something that could have been prevented.
My immediate reaction was, how do I not know about this? How have I never heard about CMV?
I lost a baby to CMV. My story is a little bit different than the average CMV family story.
When the doctor suggested that Alex be tested after he learned that there was no history of hearing loss in our family, he suggested we be tested for that he be tested for CMV. And of course, our first question is, what is CMV? We've never heard of that.
We struggled a lot with Daisy's hearing loss because she wasn't diagnosed very early. We didn't know she had CMV, and we didn't know the potential for a progressive hearing loss. And so she was identified pretty late, about 15 months old, with a hearing loss, and then lost her hearing really quickly after that.
For Weston, CMV has really impacted his hearing, and pretty much he started with hearing and ended within a year, no hearing.
By 25 weeks, I went in and there was no heartbeat on that ultrasound.
CMV stands for cytomegalovirus, and it's actually a very common virus. It's the most common virus no one's ever heard of.
It's spread through our bodily secretions, meaning like saliva, urine, sexual contact.
You don't even know you have it. You may have some very light symptoms, but generally no symptoms at all. However, if you're pregnant and you catch cytomegalovirus or CMV and you transmit it to your unborn baby, it is one of the greatest causes of birth defects. It causes more disabilities than things we all hear about, than Down syndrome, than spina bifida, than a lot of those other things.
About 20% of children that are born with congenital CMV will go on to have symptoms, and they can be microcephaly, hearing loss, visual loss, seizures, and developmental disabilities.
The thing you need to be concerned about, it is transmitted through body fluids, and so you don't want to get a body fluid on your hand and then touch your eyes, your nose, or mouth. And they think the most common way a woman gets infected when she's pregnant is through urine or saliva of a young child.
I love my son, and I want to give him kisses all the time. But when you're pregnant, just try to kiss him on the forehead. It's only 9 months. You're already making so many sacrifices, and it's worth it to have a healthy child.
As though everyone around you is potentially carrying a cold that you're trying to avoid. You know, the same way that you would if you have another child that's sick with a cold or the flu and you don't want to get it. You're washing your hands constantly. You're not sharing any beverages or food or kisses, anything like that.
For 9 months, if it could possibly reduce the risk of your child having disabilities or losing your baby, it's worth it.
Applications in medicines. A randomized study showed that when CMV-specific hyperimmune globulin was administered to pregnant women with primary infection, the rate of mother-to-fetus transmission decreased, and the risk of congenital disease also decreased. Other non-randomized studies have shown a decrease in the number of congenitally infected infants born to mothers who had been treated with hyperimmunoglobulin or improved outcomes in CMV infection infants.
hyperimmune globulin is similar to intravenous immunoglobulin (IVIG), except that it is prepared from the plasma of donors with high titers of antibody against a specific organism or antigen. Some agents against which hyperimmune globulins are available include hepatitis B, rabies, tetanus toxin, varicella zoster, etc. Administration of hyperimmune globulin provides passive immunity to the patient against an agent. This is in contrast to vaccines that provide active immunity. However, vaccines take much longer to achieve that purpose, while hyperimmune globulin provides instant passive, short-lived immunity. Hyperimmune globulin may have serious side effects, thus usage is taken very seriously. Treatment with hyperimmune globulin in mothers with primary cytomegalovirus (CMV) infection has not been found to significantly decrease the risk of congenital cytomegalovirus infection. Hyperimmune serum is blood plasma containing high amounts of an antibody. It has been hypothesized that hyperimmune serum may be an effective therapy for persons infected with the Ebola virus.
Okay, pros and cons. Pros: administration of CMV specific hyperimmunoglobulin to pregnant women with primary CMV infection significantly reduce the rate of intrauterine transmission and reduce the risk of congenital disease. And cons: overall obstetrical complications, preterm delivery, preeclampsia, fetal growth restriction.
The reason we thought that CMV hyperimmune globulin might prevent congenital infection of CMV are a couple. First, there's a long history of hyperimmune globulins potentially stopping infections during pregnancy. The second is there were prior data done in Europe that suggested that there might be some benefit of administration of hyperimmune globulin to prevent congenital CMV. Yes, the trial was stopped early at enrollment of 399 patients because the Data Safety Monitoring Board felt that the likelihood of showing benefit was so low that there was not any potential benefit of continuing the trial at that point. What we found, unfortunately, is that CMV hyperimmune globulin did not decrease the rates of congenital infection or fetal death among women with primary CMV infection during pregnancy. We also found that it did not decrease the risk of symptomatic congenital infection among those that were infected. And there was an increase in some of the side effects that we were looking for among women who actually received hyperimmune globulin. So unfortunately, we found that it did not benefit women or their fetuses or infants, and potentially had increased side effects.
Okay, is applying a way to prevent congenital cytomegalovirus prenatal control is important in pregnant women who should be vaccinated. In the case of non-vaccinated, IgG and M tests should be performed to begin treatment.
Cytomegalovirus, or shortly known as CMV, is a DNA virus that belongs to the herpes virus family, like herpes simplex, varicella zoster, and the Epstein-Barr virus. When CMV infected the body for the first time, it causes a primary infection, and then remain dormant inside the human body for life. This dormant virus may be reactivated later at any time, causing another episode of infection. Also, infected persons may be reinfected with another CMV strain. Reinfection and reactivation are called non-primary CMV infection. At least 60% of the US population has been exposed to CMV infection, and it may reach up to 100% in certain geographic areas, depending on ethnicity and socioeconomic status. CMV is asymptomatic in 90% of cases. Other patients may develop non-specific symptoms like fever, rhinitis, pharyngitis, myalgia, arthralgia, and headache. CMV is the most common congenital viral infection. About 1% of pregnant women acquire the infection for the first time during pregnancy. And about 1 out of every 150 babies are born with congenital CMV infection. CMV is asymptomatic in 90% of cases. However, the main risk is that the virus may be transmitted from the mother to the fetus, causing a congenital CMV infection. This risk depends markedly on whether it is a primary or non-primary infection. In primary infection, the risk is 40% chance that the virus will pass from the mother to the fetus. However, in non-primary infection, the risk of fetal infection is only 1%. But how can we differentiate between primary and non-primary infection? First, we have to understand the serology of CMV infection. When the virus infects the body for the first time, the immune system will produce immunoglobulin M, IgM, and about 2 weeks later, it will start to produce IgG. The IgM level will increase rapidly, peak at around 1 to 2 months after exposure. Then it will start to decrease until it becomes undetectable after about 6 months post-exposure. Similarly, IgG will increase rapidly, peak at around 1 to 2 months after exposure. But in contrast to IgM, IgG will remain detectable for life. Any time in the future, if non-primary infection happened, either due to reactivation or reinfection, this will result in another episode of IgM production similar to the primary infection. This is the classic pattern of CMV.
Okay, in conclusion, this randomized placebo-controlled trial of virus-specific hyperimmunoglobulin for the prevention of congenital CMV infection showed no significant between growth difference in AR, the primary outcome, or the secondary clinical and biologic outcome examined.
Viral infection in stem cell transplant recipients, it's pretty common, especially herpes viruses. And one of the most common viral infections usually we encounter after transplant is cytomegalovirus. But also herpes simplex, it is common, but now with the prophylactic regimen that we have and been using for years, we see much less incidence than probably cytomegalovirus infection. CMV infection is very common after transplant, especially in recipients who are CMV seropositive, meaning they have positive serology for this virus. So they've been exposed to this virus in the past. These patients are at risk for reactivation, meaning that as soon as they receive conditioning regimen and become immunosuppressed, their virus may show up in the blood and in the form of viremia or what we call deanemia. It depends on the test that you use to identify this virus. It is very common. Depending on the type of transplant, it could be between 30% up to 80%, if not more, especially in high-risk transplant, like cord blood transplant or haploidentical transplant recipients. So it is one of the most common infections that we encounter after transplant. The risk factors for CMV reactivation or even CMV and organ disease, meaning when it progresses and cause end organ damage, are practically the same kind of risk factors that we see for different infections. Usually it is the conditioning regimen can put them at risk, especially if it is a T-cell depleted regimen. It puts them at risk for viral infection, mainly CMV. But also if after the transplant and engraftment, they have graft versus host disease, which is one of the main complications in allogenic transplant recipient. This another risk factors for CMV reactivation, as well as the treatment of graft versus host disease, like high-dose corticosteroids. This will place patient at high risk of reactivation. So these are the main probably risk factors for this kind of infection after transplant, including age and probably and other comorbidities as well.
Okay, thank you.